Good morning from New York, friends and colleagues across the world. Pavel Krastev with you once again. We're having a wonderful weekend, and I hope that all of you are having a wonderful weekend. On behalf of Global Summits, myself and Dr. Kiano Shah, we welcome you to this presentation. We have a special friend out of India, Dr. Saravanakumar. And I met him backstage, and we chit-chatted, and great guy. He's going to be talking about an area that I certainly know very little about. It's called the tongue tie situation that some babies are born with. And he's going to be discussing treating it via the use of lasers. So I'm certainly very excited about it. Couple of housekeeping notes before we introduce my new friend that I'm honored to meet. Global Summits, as you guys, and I mention this sometimes repetitively because we have some newcomers and new people watching the show, so I'd like them to understand a little bit about our organization with each partner. So Global Summits is the mothership, and under Global Summits, we operate upwards of 28 platforms. So now we're branching into medicine, chiropractics, optometry, and certainly pharmacy. So we encourage all of you to, in those fields, to self-nominate, maybe consider doing a partner for us. And, so we're looking to grow in that arena. So we invite you all to look into it. What else should I say? Yesterday, we had a fantastic presentation by Dr. Shah and Dr. who's also Dean Litron of one of our newest projects on the Global Summit umbrella, and that's the Doctorate of Healthcare Business, which will be offered by the Universal School of Health, one of our newest and very proud launches of something that we're doing. And that's going to be a fantastic program where colleagues will be teaching colleagues areas that we feel were missed in professional school. So regardless of what profession you practice in healthcare, as long as you have a doctorate degree, you qualify with that alone to become one of our students and earn another doctorate, which can obviously further enhance your careers on many levels, not just in your practices, but also through innovation, through networking. You may be involved in many different theaters that otherwise may not be available to you. Another very exciting thing Global Summits is offering, and something rather new, is called the Hippocratic Certificate of Acceptance. And that's for companies and educational institutions to go through a rigorous process of evaluation and certification by the Global Summit organization that essentially their practice of their company and how they run their business operations is on a Hippocratic oath level. And once they're certified, obviously it'll be something to be positively looked upon in their portfolio. So let's introduce my new friend, Dr. Saravanakumar, and let's say hi to him. Good morning, my friend. If you don't mind, just unmute yourself.
Yes.
Good morning and welcome to the program. I had a chance to meet you backstage and we had a nice chat. So, the great thing about being me in this situation where I'm fortunate enough to be a host for many of you, I get to meet wonderful people from across the world. And once we meet, most of the time we become friends for life. So once again, welcome, Doctor. And as I said, I'm very excited about your topic. Before we get into the topic, I'd like to ask you about how is the COVID situation in India? We hear a lot about it in the news. And please give us a little update. And the reason I ask is we at Global Summit certainly care about all colleagues from all countries from all religions and all backgrounds. It makes no difference to us. So we just, our thoughts are with you guys and our prayers. And we certainly have many members who have lectured for us and who are in the Dream Team background. So, tell us what's going on. How are things?
Yeah, as you know, the more than the first wave, the second waves hit us very badly, and it's a lot of people have passed away, and the situation is very bad here. Right now, it's somehow increasing, like in north side of India, it's somehow come down, and now it's slowly coming. It's reducing. The incidence rate is reducing, and but we still face some issues with the hospitals, the facilities and other things. But we are having a vaccine drive now. We all been motivated to take a vaccine. So in that way, we are doing somewhat good. And you all know that there is a black fungus, which we know that mucormycosis. So we are doing somewhat, but it's very bad. I pray for everyone because a lot of people very near and dear, we have lost many people here.
Yeah, well, our thoughts and prayers are always with you guys and everyone across the globe. All right, guys. So let me read my new friend's resume and put my spectacles on, and then we'll get into the presentation. Okay, so I started my career as a specialist pediatric dentist in 2007. Then I earned a diploma in laser dentistry in 2011. In 2013, I went to China to complete my advanced proficiency in laser dentistry by WCLI, World Clinical Laser Institute. Then I was using lasers exclusively for pediatric dentistry. My intention to master lasers is to use lasers in management of infants' tongue ties. So I started attending eye lactation breastfeeding conferences, then gold lactation breastfeeding conferences, and tongue tie tracks. I became a member of Academy of Breastfeeding Medicine, International Lactation Consultant Association, etc. After mastering lasers and using them in adults and kids, mainly tongue tie releases, I completed nearly 100 tongue tie releases using lasers. Then on, I started using lasers for management of infants' tongue ties to assist in breastfeeding functions, chewing and swallowing issues. I am the first pediatric dentist in India to initiate the use of lasers in pediatric dentistry. That's very, very admirable. Where was I? Okay. After mastering the skill and laser knowledge, I started training the dentists in India. How effectively and efficiently the use of lasers in dentistry, especially in pediatric dentistry. I am the first pediatric dentist to get American Board Laser Surgery Diplomat, DABLS. I have received various honors and awards. Best Pediatric Laser Dentist, Outstanding Pediatric Dentist, and FICD, FISDR. I am the change to contest in International Tongue Tie Organization. I am the first pediatric dentist to get honorary membership from National Indian Lactation Association. I have been actively participating in the World Breastfeeding Week. I have done many awareness programs stating dentists are not only for teeth, they are for face and associated structures. I have been spreading the knowledge about tongue biomechanics in breastfeeding science and importance of laser as a tool in tongue tie release. I have trained many dentists worldwide. I have represented India in various international laser conferences. My motto is to start a free charitable tongue tie clinic to help tongue tie babies to do well in breastfeeding, suck, swallow, breath, speech, sleep, and oral facial complex development. I have been called as Father of Lasers in Pediatric Dentistry by the Nepal Pediatric Dentistry Association. Oh, true. Wow, that's impressive. So I see one word that pops up a lot in your bio, and that's first and the only. So you're a pioneer in this area, and that's wonderful. And I tell you something, I am really like I can't wait to see the presentation, because again, we see this thing in clinical practice often. I shouldn't say often, on occasion, and it's really nice to at least be familiar with how to diagnose it, how to treat it, so that if you choose to refer it to a specialist or to an expert, you know who to go to, and you're in the game. You know the deal. Certainly, if you are interested in treating it yourselves, here is a master on the topic who will share his knowledge and wisdom with us. So without further ado, Dr. Saravanakumar, please, I turn the podium over to you, and let's hear a fantastic presentation.
Thank you very much, Paul. It's nice talking to you before we just logged in here. And I was there in your presentation yesterday. Dream, plan, and execute. As I told you, I used to plan a lot, but execution is very difficult. Anyway, thanks for the Global Summit for this opportunity. Before I go into my presentation, I thank all the teachers, all the stalwarts and the masters who taught me, who handheld me in this journey and using lasers and how to help the breastfeeding mothers. It's a good morning to a lot of people. Happy morning. And in India, I am from south of India, Chennai, and Vanakkam. I welcome you all for this presentation. I'm just going to make it very clear, as Pavel was telling, dentistry is not only for teeth. We have something, a mighty organ inside our mouth, that is the tongue, which is very powerful, not only in the way it talks, it is also very powerful in its action. So going into my presentation, doctor has given a very good introduction. So I'm very happy for that. I straight away go to the presentation. This is the practice, what it was as a pediatric dentist. Like most of us do, I was treating dental caries, oral habits. That are the ones which we commonly see, but it's not normal. You all know that few percentage of dental caries is there in the early childhood, and we have to treat. Then my practice started. I want to incorporate something new in my practice, as we all do. We want to update, either it's in endodontics or something. Since I'm a pediatric dentist, I thought something which can do some magic, how to help the breastfeeding mothers. And I came to, when I was in post-graduation, when I was doing my post-graduation in Davangere, when my professor told me to go and search an article for the journal club, then I came across this article in 2004, which inspired me a lot. And then I started to learn about the tethered oral tissue and lasers. That time I was like very much interested to know the science behind laser, so that only once you master the tool, you will do the proper procedure. So this is the thing I thought. It's going like that. And this Dr. Fred is one who helped me a lot. If you see the bridle, it's just, I compare the tongue tie with the bridle, which restrict the movement of the horse. Same way, the restricted tethered oral tissue. One is tongue tie, which restrict your tongue, because tongue does a lot of function. It helps in breastfeeding, it helps in suck, swallow, and breathe reflex is one which is coordinated by the central nervous system, and it helps in growth and development of your craniofacial structures, because we all know when we swallow, when we swallow, the tongue has to rise up high in the palate so that it expands and it maintains the patency of the air. It also helps to speak properly. When you want to speak properly, you need the tongue to articulate, and the tongue movement is very important. You want for the proper digestion, the tongue has to move improperly to make the food in a way to digest. So if your tongue is not having a good movement, it's very difficult to clean the oral cavity. That leads to dental caries. I've seen, in my experience, I've seen few adults, they come for the root canal treatment, which a lot of teeth is being done root canal. Then when I ask them whether you know that your tongue is tight, they tell no. And when I ask them to put the tongue back and try to clean the molars like this, they are not able to do. So this is one thing I have found in my practice, which a lot of people, we don't know, and we don't see that normally, because the human superpower is that we compensate. Even if the tongue is tight, we compensate and do certain functions. We think we are doing it in ease, but we do it with difficulty. Only when someone tells you that this is how we are doing, you will come to know. So tongue plays an important role in sleep. Yes. So when you see the history, it's not a new thing that tongue tie release. It is the oldest surgical procedure, perhaps older than circumcision. So when you see the history, you have seen a lot of midwives should they grasp the honey smeared fingers. They use that to tear the frenulum with their sharp nails. This is the practice which was done earlier days. Due to ethics and other things, that practice was stopped. And then after this formula and other things, the breastfeeding rate has come down, and now the people have come to know the importance of breastfeeding, and there are a lot of things which affect breastfeeding. One such thing is tied tongue, which might affect breastfeeding. So this woodcuts show you that tongue tie procedure is not a new thing. It's not a fad. It's an old thing, and these are the instruments used for the tongue tie release procedure. When you come to the definition, the functional definition is very important than the anatomical structure. Well, you would have seen many people sending you WhatsApp photos or in your social network asking whether this is a tongue tie or a lip tie. Yes, some grade of severe tongue tie or something you can tell, yeah, it is restricted. But certain things like your posterior tongue tie, you can't tell only by seeing. You have to check them functionally. Your functional assessment is very important. That's why you tell them to come to you to do your tongue tie assessment, and you need a IBCLC or any lactation professional to do their breastfeeding assessment. So your tongue tie assessment, breastfeeding assessment, both together makes the diagnosis, and that tells you whether you need to go for the surgical release of tongue tie. So it's very important. Whether it is X-linked, it is a X-linked inheritance, and gene mutation is there on TBX22, and we see this more commonly in boys than girls. And tongue tie is associated mostly with the restricted labial frenulum, and you can even see a high arch palate associated, because when tongue is tied, it will not be able to move, and when the middle part, which has to undergo the peristaltic movement, it will not happen, and you will have a high arch palate. So these are the things you have to see when, if you think there is a tongue tie. These are the associated things you can ask and you can see. And it is syndrome associated. Any midline defect, you will see a tongue tie associated. Earlier, the definition, it is just a tissue that is short, thick. We call it as a tongue tie, the lingual frenulum. But after this study by Nicky Mills clearly states that It is a connective tissue which has a oral mucosa. It has a fascia. Then sometimes there is some insertion of the genioglottal muscle. So there are different types of restricted lingual frenulum. It can be a to and through glass-like structure, which is very easy to divide, but every anterior tongue tie has a posterior part. These are the few things you will understand once you start dividing, once you start releasing the tied tongue. So this picture clearly tells that there is a oral mucosa. Then you have the green color is the fascia, and this is the genioglottal muscle. So when your tongue is lifted, you see the lingual frenula. A lot of us think, well, how do you differentiate between the normal lingual frenulum and a restricted lingual frenulum? Restricted tethered oral tissue will restrict the normal functions. What are the normal functions? Extrusion, protrusion, lateral extrusion, all these things. Whether if it is a baby, you can't ask the baby to do all these things. So you have to see whether they have a proper latch, whether they are doing proper sucking. So these are the things which is very important. Since we are dealing with the very important anatomical structure, we should be very cautious about the anatomical vital things surrounding the lingual frenula. You can see this is the main trunk of the lingual nerve, and this white color star is the duct opening, submandibular duct opening. In my practice, as I told you, there are a lot of learning from other people, so that we refine our treatment and do the best for the babies. Yes. So I've seen a lot of restricted tongue tie where it pulls the duct with it. It will pull and it will be like in tension. Once you release the lingual frenulum, that duct rests peacefully and you will see a lot of salivation. So all these things gives a lot of release, lot of relief for the baby and the adults. So what is fascia? Fascia is a connective tissue, a sheet of connective tissue. These are the few things in microscopic pictures to show you how the fascia looks. So when the tongue tie is there, once you do some pre-operative exercises, this will help in not releasing the lingual frenulum, making the fascia settle down in a proper way, so that it will help in the healing process. So a lot of us have a doubt whether this lingual frenulum goes off as we grow. If it is so, we will not see any tongue-tied adults. I've seen even tongue-tie at the later age, by 60, 70, they don't know that they are tongue-tied, and they just happy with their life. They have sleep issues, all because they tend to compensate. They tend to compensate in a way so they don't feel any difference. So whether the tongue tie get corrected by itself, no, it will not get corrected by itself, because the collagen fiber present in lingual frenulum is found to be type 1, which will not release or will not get corrected by traction or stretching exercises. This is one thing you have to understand. There are a lot of external and internal muscles associated with the tongue, and one important muscle is genioglottal muscle, which might intervene in the lingual frenulum. So when you do tongue tie release, you have to be very curious whether you're going to release the fascia properly and check whether the genioglottal muscle is free of tension. So this is a classification given by Kotlow. I've learned a lot of things. He's one of my guru. So this classification clearly states that type 1 is tip of the tongue is tied. That is the heart-shaped tongue. So when you see a heart-shaped tongue, the tongue doesn't go beyond the lower lip. This is the only criteria which the ICU sisters, NICU sisters used to check for the tongue tie. They never check any lateralization or whether the lifting of the tongue, how it is. So when you see the type 2, the lingual frenulum is attached more distally to the tip of the tongue. So the midline area under the tongue creating a hump or cupping of the tongue. So type 3 is the lingual frenulum is attached some more distal. So you might see a lot of type 3, whether to release or not, it all depends on the tongue function, whether there is associated symptoms or not. And this posterior tongue tie, and I call it as hidden tongue tie, and a lot of people call them it as a submucosal tongue tie. This is very important to, very difficult to identify, and it causes a lot of issues in breastfeeding because the middle part of the tongue has to move up and down to create a negative pressure so that the milk from the breast is drawn into the infant's mouth. When you see the restricted labial frenulum, there are different types, and this labial, the lip tie release is more, again, depends on the symptoms. We have to, as I told you, the tongue tie assessment, lip tie assessment with breastfeeding assessment helps you to do a good job. There are different tongue tie assessment tools. There are some assessment tool which sees only the anatomical structure, but you have to see the anatomical structure as well as the functional assessment. This tool gives you a picture to see how the tongue tie is being scored accordingly. This is from UK TABI assessment, tongue tie assessment. The scores, as the score is lower, the severity is more. 5 or below suggests there is an impairment of tongue function. This may or may not be having an effect on breastfeeding. So in my experience and a lot of things, how I learned from a lot of people who are working with the infant's tongue tie, we see few mom who is smart enough and baby is smart enough to do a good job. Even though they are tongue tied, they compensate and they don't have any breastfeeding issue. But later, if there is a tongue tie, they might have issues with chewing and swallowing, and they might have issues with speech. So all this plays an important role. And this is the functional assessment tool, which shows you the anatomical appearance item and the function items, where you see both the things, the lift of tongue, the length of lingual frenulum when tongue lifted. So you have to use these assessment tools so that you can come to a conclusion how you're going to, whether you're going to observe or you're going to do the surgical release. And these are the other pictures to show you how the free tongue, what is the distance between the tip of the tongue to the lingual frenulum. If it is measured like 16 mm and 12 to 16 mm is class 1, 8 to 12 mm is class 2, and if it is less than 3 mm, it is class 4, and it is very severe. That is what we tell it as heart-shaped tongue tie. And these are the pictures again to show you how restricted lingual frenulum has various issues apart from breastfeeding. It's not only breastfeeding, it has poses various other issues like articulation, speech, to do a proper chewing and swallowing, which helps in digestion. So there is no any reflex, gastric reflex issues, and the tongue needs to go around the mouth to clean the oral cavity. So all these things plays a important role. See, these two things look similar, but it's different. That is what, when I started looking, my eyes were seeing always, whether it's a restricted lingual frenulum, your eye see what your brain knows. This is what I used to feel. When I thought of starting a dental clinic, wherever I go, I see there's a lot of dental clinics. When I want to buy a car, the model which I like, I used to see the same model everywhere. This is the something related psychologically. So, but still, it's very important to diagnose properly and do the needful. The lingual frenulum is a small tissue, but the symptoms, the issues associated with this, it's very huge. This is how I just want to compare. When you see it's a small tissue, but the fascia attachment is somewhat restricting the even the movements of the shoulders and your neck. My friend Dr. Dan from Australia has given this model which clearly tells you that when there is a tongue-tied infant, there is breastfeeding difficulty, colic, mouth breathing, and in children, the growth of craniofacial complex is compromised, and they might have speech difficulty because your tongue has to lie up in the palate. That's what we tell, close your lips, tongue up, and breathe through nose. So these three things is very important for overall health. Once, if the tongue is not lying up in the palate, when it comes down, it drops down, the palate will get constricted, the upper airway patency is disturbed, and it gets narrower. So your sleep is disturbed. In a way, it will affect the cognitive issues. The child might not do well in the schools. In adults, you have the other issues like your sleep apnea and other issues. Breastfeeding moms, it's a big salute to them, because I've seen many moms, they do very well and some suffer, and it's a difficult task to bring up the child. One such issue which might affect the breastfeeding mechanism or breastfeeding medicine is tongue tie. So once, if you assess properly and if you see it's tongue tied, then you can release the tied tongue in order to help the breastfeeding diet. This article by Lawrence Kotlow, which clearly tells you have to search for a new box. It's not the other way around. So we have the capability to learn the skill, and start doing with the proper tool and help the breastfeeding mothers. What are the symptoms? How you know whether the baby is tongue tied? There are baby symptoms and mom's symptoms. The mom might have cracked nipples, blisters, blocked ducts, and the nipple might be like a lipstick shape, and all these things are there. But once you get a opinion or consultation with the lactation professional, they might help you in changing the position and other things. If it is not tongue tied, all the other skills what has been provided by the lactation professional will help the mother in a very big way. And what are the symptoms you see in a baby is the bloating of the stomach, the gumming, a gassy baby, and excessive drooling might be there. You might hear a clicking, snap back sound because the tongue was not able to hold for a long time. It drops. you can't hold it for a long time, it will drop. So you might hear a snap back sound. So this the photographs, thanks to Mitchell, who tells that mouth opening should be 130 degrees to have a proper latch, so that you can, which helps in proper breastfeeding. The pain is very severe. I've seen many mothers explaining it's very pricking, burning pain. It's very difficult. We have to understand the problem and try to help them out. This is one study which tells 1 in 10 babies born with a tongue tie that affects their ability in breastfeeding. After seeing this slide, I also went to my state government and told that releasing restricted tongue tie, restricted lingual frenulum is very important. It is an emergency. We're going to help the breastfeeding diet. This, in a way, it's going to improve the baby's weight. So it's how you check whether there is a proper suck reflex is there or not. You can just feel the tongue movement and check how it is happening. This article clearly tells you the tongue kinematics. There is a quantitative imaging of tongue kinematics during infant feeding and adult swallowing reveals highly conserved patterns. So there is a lot of things what they have done. In 2014 also, David has done an study to find out how the negative pressure is happened to extract the milk from the breast. So the method clearly displayed the improvement of tongue motility after frenotomy in infants with either tongue tie or restricted labial frenulum. So the junction, the hard soft palate junction, how the tongue has a peristaltic movement, which is going to help to create a suboptimal pressure, which is going to help in extracting the milk from the breast. So the tongue movement is very important for breastfeeding mechanism. Similarly for speech, for swallow, and for sleep and breathe. This is a picture to show you how the peristaltic movement starts from the anterior tip of the tongue and it moves from middle to the posterior of the tongue. So if only the anterior part of the tongue is more free and mobile, or the movement is good, the middle part, if it is not moving in a way to do the proper breastfeeding mechanism, it's going to affect, and the mother will have a severe pain. These are the few clinical pictures to show you the different types of tongue tied. Posterior tongue tie, the tip of the tongue is tied. We call sometimes as a Eiffel Tower tongue tie, and this is like a class 2. And these are the few things which I thought I should show you the clinical pictures. And this is another baby where there is a lip tie and there is a tongue tie. So when you see the lip tie and tongue tie, and if it is associated with the breastfeeding issues, before the procedure you have to do certain pre-procedure oral physiotherapy, and then you have to go with the thing. Earlier I was doing like this. After learning a lot of things, we thought it's not the right way to put the baby on the parents and do, because it's always better to stabilize the baby in the table and then do with the proper restricted head movements and other things. This is how it looks when you do a lip tie release using a diode laser, and it's how it looks after a tongue tie release using a diode laser. I use diode and erbium, but more than 5 years I am not using a diode for the infant's tongue tie release. I'm using only erbium, which is purely cold laser, which helps. Even diode I use in certain situations with proper cooling effect and other things. So you have to know how safely, effectively, and efficiently you can use lasers to release the restricted tethered oral tissues. Give instructions to the parents what has to be done before and after the procedure, what all precautions to be taken, so that you will be in line with them. It's a teamwork. We all work together, pediatrician, lactation professionals, social workers, and speech language pathologist, pediatric physiotherapist. So it's a teamwork. So we all need a proper coordination. So this is how when you do it for a child, you tell, show, and do. And this is a picture to show you how we have released the tongue tie using a diode laser, which affected his speech, which he was not able to speak properly. And we have a lot of videos after they send us audio video things of the baby, how they speak and how their pronunciation has been improved a lot. Even in general anesthesia, if you see this severely restricted lingual frenulum, it's not even lifting. You are not able to see even the tip of the tongue. It's very severely restricted. Since the age is around 3 to 4, we don't manage in the chair side. We do it under general anesthesia, and you can use lasers in general anesthesia, but you have to instruct the anesthetist about the laser use. This is an anatomical structure just to show you how close to the anatomical structures we are working. And this is what we should not do. This is a very severely injured lingual frenulum because of the diode laser. Just a small slide to show it's all about a lot of learning, and it's you learn, unlearn, and relearn. So you can do the best for the infants who trust you after baby is born. After mother who is holding the baby, it will be the next person will be you who holding the baby. Even the father would have not hold the baby. So you should be more working under the humanity grounds. You should train yourself and then touch the infants. Kindly take my word, please. Evidence, a lot of evidence, a lot of articles which tells there is a lot of studies, Cochrane study, then there is a lot of meta-analysis, randomized control trials, which tells frenotomy helps in improving the breastfeeding, reduce the breastfeeding pain, nipple pain. And this picture is to show you how people miss out the posterior tongue tie. They might see the normal movement of the tongue, but if you don't palpate or if you don't manipulate properly and see the restriction, this is what is going to be missed out. You will not able to check the posterior tongue tie if you're not doing it properly. And the mother keeps on telling there's a pain. You have a team, lactation consultant will be there. So it's better you identify it properly. This is an article to show you that frenotomy for posterior ankylosing may improve breastfeeding and nipple pain. There's a lot of other supporting articles in there. This article by Richard, who clearly tells that in his 5 cases which he has done, intervention from a speech language pathologist is very important, but there is a very huge improvement in feeding as well as speech. Many of a lot of people, they complain the tool. This is a very good video in YouTube to show you the poor workman always blames his tool. Just few more slides to show you how we are using the wrong tool. The effort plus wrong tool equals no results. In my experience, what I have seen is not experienced provider plus right tool, no results. Experienced provider plus right tool plus wrong diagnosis, no results. Experienced provider plus right tool plus right diagnosis plus wrong team. Even the parent, the mother is very important, no results. So you need all this together to get the best results. This is one thing which I've learned. And the other people who are around the world who are pioneer in this have told that just snipping with the BP blade or scissor, it's not going to help. You have to do a functional tongue tie release, which is going to which will be easy if you are using a laser. American Academy of Pediatric Dentistry have very clearly stated that laser as a beneficial instrument in providing dental restorative and soft tissue procedure for infants, children, and adolescents. So there are a few more slides. Is it fine, Pawan?
Yeah, absolutely. Please go ahead.
Yeah, you have some more time. Okay. Yeah. So the advantage of laser, as the recent guidelines, they clearly tell that the use in pediatric dentistry is a selective and precise interaction with the diseased tissue. There is less thermal necrosis if you use it properly. If you are not knowing how to use it, you're going to harm the tissue, you're going to harm the child. And the healing is going to take more time than the naturally conventional type of healing. So you have to be very careful, even if you're using a scissor, if you're using any other tool, only if you get trained using it. That's what I have told you have to use more in adults, then you come to the infants. The benefits of hemostasis is there. Wound healing can occur more rapidly with less post-operative discomfort. This is one thing we see with the laser if used properly, and a reduced need for analgesics. Laser demonstrates decontaminating and bactericidal property on tissues, requiring less prescribing of antibiotics. This is for the adults. We don't do this for the infants. We don't give any medication. If needed, we might give some sucrose solution before the procedure. And after the procedure, if they are okay with the homeopathic, or we might go for the allopathic medicines. This is a policy which has been recently given by AAPD, American Academy of Pediatric Dentistry, that laser technology for frenotomies and frenectomies has demonstrated a shorter operative working time, a better ability to control bleeding, reduced intra and post-operative pain and discomfort, fewer post-operative complications, no need for suture, and increased patient acceptance. This all the few advantages of laser. Yes, we are using a tool which needs laser safety. It's very important. Laser safety goggles are there specific for the infants. You have laser safety iPad is there, disposable pads are there. So you have to know the laser safety, and then you have to start using. There are a lot of training is needed. You have to use lasers in a way so that the laser what you're using, you have to master that so that you can do the best for the children. So this is again a thing which I like to display, that some courses offers written examination which validate a certain knowledge of knowledge, but competency and operational skills must be validated with the user's own equipment in a suitable manner in his or her clinical workplace. This is very important. Education must be an ongoing effort to stay current with the technology through journals, conferences, networking, and professional organizations. I think I have done with my presentation. I've started with the sun and ending with the sun. The three things cannot hide for a long time: the moon, the sun, and the truth. And in my presentation, I like to tell the fourth one is tongue tie. You can't hide a tongue tie for a long time if many providers have been educated in a good way. Thank you for this opportunity and a global platform. Thanks a lot. Thank you very much.
You are most welcome. This was a fantastic presentation, as all presentations are. But you know something interesting. It's so exciting to see how much one can learn from the comfort of their chair. Typically we would have to travel here, there, airplanes, hotel rooms to gain knowledge. And Dr. Shah pioneering this global effort involving colleagues from across the world to share knowledge with the doctor-to-doctor or D-to-D movement, as we call it, is just amazing. I mean, anytime you watch a seminar like this, you always walk away with a thing or two that stay with you. And one day you see it in your practice, and boom, you have an idea what's going on, because we cannot be experts in all fields, in every single specialty in dentistry, in every single clinical treatment. Most of us are general practitioners, some specialists. So it really varies. There's a whole gamut of who does how much and when. But one point you made earlier that really struck me, and it makes so much sense, is what you said about psychology. And when something is, you've seen it 1,000 times over and over and over and over, I guess the repetitiveness of it makes an imprint in your brain, and sometimes leads your eye to see things that you normally wouldn't have seen. So I thought about that after you said it. I said to myself, man, I said, that's so true, I have two questions myself, and then we can turn it to the audience. You mentioned that the prevalence rate is 10% or so, 1 in 10 babies. That's a lot. I personally, I had no idea it was that high. I mean, 10% of all babies being born with tongue tie, a condition obviously that can interfere with feeding and speech. That's a lot of tongue ties that we have out there to treat. So it's certainly very exciting, very interesting. The other thing that I wanted to ask, and perhaps you mentioned it and maybe I missed it, what is the ideal age when a dentist or surgeon should treat tongue tie?
Yes, the first one is the prevalence. Earlier, they were telling it's 2 to 3% because the diagnosis is very important. The diagnostic criteria is very important because they are only seeing the tip of the tongue is tied. So they were giving a very small percentage of prevalence. Then once they able to check with the other classifications and other things, they came to a prevalence rate of 10%. It is even higher. In few studies, they have told even it is higher than 10 to 20%. It's similar. It's like that. So the prevalence rate is not like 2%. Like earlier in my school days, I was studying tongue tie is 2 to 3%. It is more because they were not seeing the criteria for diagnosing. The classification was not very clear. Only the tip of the tongue they are seeing whether it's tied or not. The second one is the age, at what time you have to do a tongue tie release. What I have seen is the first 7 days, if it is severely tongue tied, even by 4th or 5th day or as early as possible we can do. If not, then you can wait for the natural process to happen. The baby can have the natural reflex to go to the breast and try to do some suck reflex training, and then we can wait and then do after 7 days. This is what I follow in my practice. A lot of people, they don't come within 1 month or 2 months. They come only after 2 months because they wait for a long time. They would have had some let down, and they have some kind of hormonal efforts which is making them to help in breastfeeding. But after that, they will have a lot of issues because of tongue-tied babies. So they might come after 15 days or 1 month. Very few people, very few babies I have done 4 days, 5 days, or 7 days. But maximum we have done by 1 month or 2 months. And there are babies who come by 9 months or 8 months. All that because of psychologically, they don't know where to go, what to do. So they will be Googling and searching a lot of Facebook support groups. And that is how they end up.
And furthermore, now that we're talking about age, in my practice, we have an adult. When I say adult, he's probably, I'm going to assume, I can't remember off the top of my head, but I'm going to say 15, 16. And I referred him to the oral surgeon maybe last time I saw him some time back, and he still hasn't had it removed. So my next question is, when we have an adult who has never addressed the issue, who's never had it treated, do we still treat it? Do we still recommend treating it? What's your opinion on that?
Yes, we humans are supernatural power. We compensate nicely, even if it's a tongue tied. We learn how to talk with a tied tongue, how to chew, how to eat, and all these things would have been done. Your brain neuroplasticity will learn. See, in our dental school, we use a micromotor. I think nowadays we are not using. The speed is somewhat, it increases to aerotor. Our neuroplasticity will get adapted to the hand speed and other things. Same way, the tongue-tied adults will have adaptation. But if they have an issue, I have done a lot of tongue-tie release for adults who come to me and tell that they have difficulty in answering immediate response to the interviews. They go for the interview, they will not be able to immediately respond. They take some time, they get stammering. So those who have come for certain issues of speech problem, we do tongue tie release, but it will not give immediate results because your brain has to unlearn and relearn. It's just like your software, you have to uninstall and reinstall. So it will take more time. If you do your tongue tie release in early days, early stage, your brain while learning itself, it learns in a good pattern. So this is the difference. You face problems.
That's very interesting. I think now I shouldn't make this joke, but I think I'm going to put a sign in my office that I'm starting to treat tongue tie, and I promise people they will kiss better after the tongue tie is released. Maybe I'll become famous for treating tongue tie and making people better kissers. What's wrong with kissing? Loving people. Hey. Anyway, listen, that was great. Let's take a look at our audience if they have any questions for you. Do we have any comments? Do you see any questions? Anyone, guys? All right, so I guess while we wait a few minutes to see if there's any last questions, I would like to mention one last thing, which in one of the shows that we did with Dr. Michael Davis a week ago, Dr. Davis brought up a very, very good point, and I wanted to clarify it. Very often when I speak, I refer to you guys, you ladies and gentlemen, but when I say you guys, it's not referring to men only, because in America, in the United States, we very often say, hey guys, to both sexes, and men and women, and ladies and gentlemen alike. So I want to be sure, as I try to improve my habit of saying you guys, that all of you out there in the audience are assured that when I say you guys, I mean men and women. And I certainly believe that dentistry and medicine is equal mix of ladies and gentlemen. And that's how I was trained, and that's how it is. So the lovely show. Let's no questions, I guess. In that case, my new friend that I call you now, it was a pleasure having you. I look forward to, again, a lifelong friendship with you, like many others. And thank you for finding the time and doing this for our audience. And to our audience, enjoy the rest of your weekend. But before you do that, stay tuned. As they say, don't touch that dial, because we have 2 great shows coming up. All right, folks? So stay tuned. Don't touch that dial. And on behalf of Global Summits and the VGO man, Dr. Pavel Krastev, love you all. See you next time.